Okay, so welcome back to this next video in which we are discussing diabetes mellitus and anti-diabetic drugs. Okay, right. So in this next video what we're going to do is turn our attention onto the chronic complications of diabetes mellitus. Okay, now the chronic complications can be divided into two separate categories. Okay, there is the chronic complications that are macrovascular, okay, which means that they're going to occur in large blood vessels, okay, and then there are the chronic complications which involve microvascular disease, which are going to occur because of problems with smaller blood vessels. Okay, right, we are going to start off with the macrovascular consequences of diabetes. Okay, so the chronic complications of diabetes result because of hyperglycaemia. Okay, they result because of both the elevated fasting blood glucose level and also because of the larger and more broad postprandial glucose spikes. Okay, so hyperglycemia is going to cause the macrovascular and microvascular diseases that are associated with diabetes. Okay, so let's start off with the macrovascular pathology associated with hyperglycemia. Okay, so macrovascular, it's going to occur in big blood vessels. So the big blood vessels are the ones which you learn about in anatomy, the ones whose names you learn, basically. So the aorta, the coronary arteries, the carotid arteries, the renal arteries, okay, the brachial arteries. All of these arteries are macrovascular blood vessels, big blood vessels, whereas microvascular refers to small blood vessels which don't have names, so arterioles and capillaries. So we'll come on to microvascular disease later on. So let's start off with then what happens in big blood vessels because of hyperglycemia. Okay, so basically chronic hyperglycemia, both in the fasted state and also particularly the taller and broader postprandial glucose spikes, these are going to cause accelerated atherosclerosis, the starting point for most cardiovascular disease. Okay, so it's going to lead to atherosclerosis. Now, how does it lead then to atherosclerosis? Well, atherosclerosis begins with damage to the endothelial cells of the blood vessels. Let me draw a picture here. Okay, so if I've got a blood vessel here, this is a very, very large blood vessel, maybe some large artery. Okay, so I'll draw it having a big thick wall. So the inner layer of the blood vessel wall here, which I'll colour in yellow, this is the endothelial layer, okay, which actually lines the blood. Now if the blood contains a far too high glucose concentration, particularly in these massive great postprandial spikes, okay, then what that incredibly high blood glucose concentration can do is it can cause damage to these endothelial cells, and that begins the cascade which leads to atherosclerosis. Okay, so you get immune cells invading into the space underneath the endothelial cells, which is full of connective tissue. Okay, you also get LDL particles leaving the blood and going into that area, and it causes a massive great swelling on the side of the blood vessel, which is known as an atherosclerotic plaque. Okay, now what are the consequences of atherosclerosis? Well, basically, if we now draw the blood vessel as viewed in a cross-section, okay, so this is the normal healthy blood vessel. Now let's draw it with an atherosclerotic plaque. Okay, what you'll have is now a huge great plaque sticking out and obstructing the wall, obstructing the lumen of the blood vessel. Okay, so this is your atherosclerotic plaque, all of this here, and it obstructs the blood vessel basically. So this is what's known as an atherosclerotic plaque. Okay, so too high blood glucose level is one of the driving forces for the development of atherosclerotic plaques. Okay, there are other driving forces as well, such as hypertension and smoking because of the horrible chemicals that are in cigarette smoke. Okay, but diabetes is a major cause of it. Okay, so what are the consequences of then getting atherosclerotic plaques in your large arteries? Okay, well, the two main ones are that it can cause heart attack and stroke. Okay, so basically when you get atherosclerotic plaques occurring within the coronary arteries, which are the arteries that supply blood to the heart, okay, what that firstly leads to is something known as coronary heart disease. Okay, so initially what happens is the blood flow to the heart is obstructed, but the heart copes, okay? You deliver just about enough blood that the heart can live with that, okay? The problem occurs when you try and exercise, okay? Because when you try and exercise, the heart then needs more blood because it's needing to pump faster and also harder so that we can deliver more blood to the peripheral tissues such as the skeletal muscle cells, okay? But if the coronary arteries have these large atherosclerotic plaques which are obstructing their lumens, then basically they can't dilate in the way that they would normally do, okay? Normally what happens is when you exercise, the coronary arteries dilate, okay, to increase the size of the lumen, and that allows more blood to go to the heart, and then the heart copes with the increased heartbeat and increased force of contraction because it's getting more blood delivering oxygen and glucose, so it can maintain that behavior. Okay, now with the atherosclerotic plaques, the arteries end up fully dilated even at rest. Okay, they dilate so that the lumen is large enough that you can deliver enough blood when you're at rest, basically when the heart is beating at normal rate. Okay, and when you then exercise, you can't dilate anymore, so you can't get increased blood to the heart, even though the heart needs an increased demand. Okay, so that's initially coronary heart disease. So when you actually exercise, you get a crushing chest pain, which is basically your heart saying, we haven't got enough oxygen and glucose here. If you don't stop, you're going to have a heart attack. And that crushing chest pain is known as angina, which means a crushing pain. And then pectoris, which means pertaining to the chest. Okay, so a crushing chest pain. So initially, atherosclerosis in the coronary arteries causes coronary heart disease, and the symptom of that is angina pectoris upon exercising. Okay, now if this becomes especially bad, it can lead to a heart attack. Okay, so if you get potentially certain portions of the heart getting completely no blood, okay, then that results in that portion of the heart dying, and that's known as a myocardial infarction. Okay, myocardial means pertaining to the muscle of the heart, and infarction means dying due to lack of oxygen. Okay, so coronary heart disease and angina pectoris, they can lead to myocardial infarction, and myocardial infarction, often abbreviated as MI, is often fatal, but if you do survive it, it can then propagate onto other things such as congestive heart failure and also dysrhythmias. Okay, so that's very, very serious. Okay, the other serious place that this can occur is in the brain. Okay, so if you get atherosclerosis in the blood vessels that supply the brain, okay, so let's say brain blood vessels, okay, then certain portions of the brain can have too little blood supply because of the obstruction of the lumen of that blood vessel, okay, and this can lead to portions of the brain dying, and that's what's known as a stroke. Okay, or the more official term is a cerebrovascular accident. Okay, cerebrovascular accident, which is often abbreviated as a CVA for short. Okay, and again, strokes can often be fatal. If you do survive them, they can lead to huge deficits, okay, because now you've lost a portion of the brain. And it's important to say that the reason losing blood supply to a certain portion of the brain or the heart is particularly bad is because these two tissues, which are the most essential tissues of the entire body, have the worst capacity for regeneration, okay? The heart cells and the brain cells do not divide as a general rule. Okay, we're starting to see, especially in the brain, that this rule is starting to be broken. We're starting to find areas where brain cells do divide. But as a general rule, heart cells and brain cells do not divide. The cells that you have in your heart and your brain now were the same cells as you had when you were born, okay, which is why when they die because of lack of blood supply, you can't then replace them, okay, and I for one find that slightly curious that the two most essential tissues of the body, the heart and the brain, have the worst capacity for regeneration, and this is why lack of blood supply to these two tissues results in the most serious consequences. Okay, right. So that then is the consequences of macrovascular disease in type 2, in diabetes mellitus. Okay, you get atherosclerotic plaques forming in your large blood vessels. When this happens in the coronary arteries of the heart or within blood vessels in the brain, this can lead to very serious infarctions of brain tissue and also heart tissue. Okay, which can lead to very serious diseases. Okay, so now let's turn our attention onto the microvascular disease. So the microvascular disease involves changes in capillaries and arterioles, tiny little blood vessels basically, okay, that's going to cause problems in certain areas of the body. Okay, so microvascular disease causes problems in the kidneys, it causes problems in the retina, and it causes problems in nerves, okay, and I want to discuss the pathology of each of these. So often people say that microvascular disease results in diabetic nephropathy, diabetic retinopathy, and diabetic neuropathy. So we're going to go through each one of these in turn. Okay, so we're going to start off with diabetic nephropathy, okay, which means problems with the nephrons in the kidneys. Okay, and this can result in very serious disease. It can result in renal failure eventually. Okay, now, what happens then in nephropathy is that you get sclerosis of arterioles in the kidneys. Okay, now let me just remind you of the structure of the kidneys, the structure of the nephron, and particularly the structure of the glomerulus, because we're going to need a decent understanding of that in order to understand what's going to happen here. Okay, so firstly, let me show you a picture of the kidneys. Okay, it's only going to be a very basic picture. Okay, so here then is the ureter. Okay, and then here is the left kidney that I'm drawing here. Okay, like so. And then what we're going to have is two major portions of the kidney. There is the renal cortex and then there is the renal medulla. So let me firstly draw the renal cortex. Okay, so all of this is the renal cortex with little renal columns extending forth from the renal cortex inwards like so. Okay, there. Right, so this portion here, this outer portion is known as the renal cortex. Okay, and these little extensions of the renal cortex inwards, okay, these are known as renal columns. Okay, so let me add a little bit of colour onto this picture. So I'll colour in a renal column in red here. Okay, so that's a renal column. So we've got, this is a renal column, this is a renal column, this is a renal column. We've got 5 renal columns there. Okay, and then this portion out on the outer portion of the kidney is the renal cortex. So cortex literally means the outer layer of the kidney. Okay, and then amongst the renal columns you've got the other portions of the renal medulla. Okay, known as the renal pyramids, which sit in between the renal columns here. Okay, so I'll colour these in like so. So these are all renal pyramids. So we've got, how many have I put on here? 6 renal pyramids. Okay, it will vary depending on which cross-section you take. These are little areas, okay? You have multiple of these in each kidney. Okay, so here then, this in orange, this is a renal pyramid. And the renal pyramids and the renal columns together, they make up the renal medulla. Okay, so this portion here, the more inner portion of the kidney, that's called the renal medulla. Okay, and each one of these little sections in between the renal columns, which I'm colouring in orange here, okay, these are the renal pyramids here. Okay, like so. Okay, right. So that's the broad anatomy then of the kidney. Oh, actually, I haven't quite finished this picture yet. This space in the middle is where all the urine is going to collect, and this is known as the renal pyramid. Sorry, not the renal pyramid. The renal pelvis. Okay, so all the urine is going to collect in the renal pelvis, and then it's going to drain into the ureter here, and of course this is the left ureter that we're seeing here, and then that will drain into the bladder, which will be further down, and then you'll have the urethra, which will connect the bladder with the external world. Okay, right, so that's a brief overview of the structure of the kidney. Now let's have a look at the structure of a nephron. Okay, so nephrons are going to be located in the renal cortex and the renal medulla. Okay, they start their life off in the renal cortex. What I'm going to do is I'm effectively going to take this portion out here, and we're going to have a look at a nephron in this portion. Okay, so I'll draw the nephron here. Okay, so you start the nephron off with a structure known as Bowman's capsule here. Okay, then the first section is a little portion known as the proximal convoluted tubule here, which has a very convoluted structure, and all of this is currently in the renal cortex. So all of this portion, this is the renal cortex basically, so this will be up in this portion. Then it's going to dive down into the renal pyramid here, okay, like so, in a structure known as the loop of Henle. So here comes the loop of Henle, diving down into the renal pyramid, okay, and then coming back up into the renal cortex, like so. So this long tube looping down like so, this is the loop of Henle. So this is the loop of Henle. Okay, then after the loop of Henle, what you have is another convoluted tubule, known as the distal convoluted tubule, here. Okay, and then what it does is it opens out into a collecting duct along with loads of other nephrons, and the collecting duct will then go back down through the renal pyramid again to drain into the renal pelvis at the bottom. So this will drain out onto the bottom, and this is the renal pelvis. Okay, so this structure here is known as a collecting duct. Okay. This is the distal convoluted tubule, which for short I'll abbreviate as the DCT, okay, and this is the proximal convoluted tubule, PCT. Okay, then here we have Bowman's capsule. Now this is the structure we're going to be incredibly interested in, okay, because this is going to have the glomerulus within it. So let me draw a bigger Bowman's capsule down here, okay, so here is Bowman's capsule here, like so, which is continuous with the proximal convoluted tubule after it, like so. And then what you're going to have is one arteriole coming in here, okay, which will be known as the afferent arteriole, and another arteriole going out over here. And then in between, what's going to happen is the afferent arteriole is going to split into loads of separate capillaries, okay, which are all going to bundle together in this Bowman's capsule here, like so. So I'll try and show this here. Okay, so I'll only show 3 separate capillaries. In reality you might have more than that. Okay, so I'll try and colour it in to make it clearer. So here is this big, well, reasonably big compared to the capillaries, blood vessel known as an arteriole. Okay, and because it's coming into the Bowman's capsule, it's known as the afferent arteriole, which means coming into. Then you've got the capillaries, which we're splitting into here. Okay, this cluster of capillaries, which is going to be clustered in the Bowman's capsule here. Okay, and then you go into another arteriole, not a venule, it's another arteriole, which is known as the efferent arteriole. Okay, so let's put some annotations on here. So this blood vessel coming into the Bowman's capsule here, this is known as the afferent arteriole. Okay, and then it splits into loads of separate capillaries here, and this cluster of separate capillaries, the whole thing is known as the glomerulus. Okay, so the glomerulus is the name for the entire cluster of capillaries here, not just a single capillary, it's the entire cluster of capillaries. Okay, and then coming out of this, you then have the efferent arteriole, which is the arteriole going away from the Bowman's capsule now. Okay, now you might be wondering, well, why is it not a venule? Well, it's going to go on and collect blood. Well, it's going to collect things which have been reabsorbed from later portions of the nephron here. So this structure, I should have actually said, this is an entire nephron that I've drawn here. Okay, so the afferent arteriole is going to come out, and then it's going to be giving blood to all of the cells of these later ducts, and it's going to be taking the things that these cells of these ducts here have reabsorbed from the fluid that's moving through these tubes, and it's going to be taking it back into the blood, basically. Okay, right, so just to give you a brief overview of what nephrons do. Basically, in the glomerulus here, blood fluid is going to be squeezed out of the blood basically into the Bowman's capsule here. Okay, you're not going to squeeze blood cells out. The red blood cells are going to stay here, but the fluid, the blood plasma, is going to be squeezed out into Bowman's capsule here. Okay, this fluid is now going to move through the entire nephron until it then goes into the collecting duct. Okay, and all the way along here, the cells that line these tubes are going to be taking little good things back out of the plasma that's going through this tube and returning it back into the blood. So you'll have a blood vessel. If I draw this with the highlighter, here comes the efferent arteriole coming out of the glomerulus here. So I'll draw the glomerulus here. Okay, this is the efferent arteriole. This will now run alongside all of these bits here. Okay, and will take the blood back from these, the cells of these tubules, basically. So little things that are good within the lumen of these tubes, the cells that line the tubes will be taking those out and putting them back into the blood, okay, so that we're not throwing away good stuff, basically. Okay, and what will then be left over by the time that the collecting duct drains into the renal pelvis will be all of the waste products in a fluid that you don't now want to reabsorb, and that's the urine that will be in the renal pelvis, and that will then go down the ureter to the bladder. Okay, right, so it is these afferent arterioles and these efferent arterioles that are going to be get diseased basically in diabetic nephropathy. Okay, so you're going to get something that's known as nephrosclerosis, okay, which involves arteriolosclerosis of the afferent arteriole and the efferent arteriole. Okay, so let me put this on here. Okay, so the afferent arteriole and the efferent arteriole are going to get something known as hyaline arteriolosclerosis. Okay, now let me draw you a cross-section of what an arteriole looks like so that we can understand what is going to happen in hyaline arteriolosclerosis. Okay, right. So firstly, let me just tell you what this means. Arteriolosclerosis means that you're going to get hardening of the arterioles. Hyaline means a glassy appearance. Okay, so the thing that causes this hardening, the new structure is going to have a glassy appearance, and I hope this will become more apparent when I actually draw it out. Okay, so let me draw a cross-section then of an arteriole. Okay, so this is our afferent arteriole. Now firstly I'll show what it should look like, and then I'll show you what it's going to look like after a long period of hyperglycaemia. Okay, so arterioles consist of two major layers. Okay, you have the endothelial cell layer here, which are the cells that actually line the lumen here. So these are endothelial cells lining the lumen. Okay, those endothelial cells will be sat on a basement membrane, which I'll show here in turquoise. Okay, and then around the basement membrane, you'll then have a few layers of smooth muscle cells. Okay, so these cells that I'm drawing here, these are supposed to represent smooth muscle cells. Okay, so here in red, these are smooth muscle cells. Okay, so these are the two main layers then of arterioles. You've got the smooth muscle cell layer here, okay, and these smooth muscle cells will be arranged in circles around the arteriole, okay, and when they contract, of course, that will mean that the entire circumference of this loop of smooth muscle cells contracts, and that will mean that the entire blood vessel constricts, basically. Okay, so this is the smooth muscle layer. And then you've got the inner layer, which is made up of endothelial cells. So this is the endothelial cell layer. Okay, right, and of course the endothelial cells are sitting on the basement membrane, which is supporting them. Okay, so this could be our afferent arteriole. Now what's going to happen in hyaline arteriolosclerosis, the chronically high blood glucose level, okay, both fasting blood glucose level and also the problems with the postprandial glucose spikes that occurs in diabetes, is going to cause changes to this arteriole. Okay, you're going to get a huge new layer being produced, basically. So I'm going to show this to you now. Okay, so now what's going to happen is the lumen of our blood vessel will be hugely reduced. Okay, we'll have our basement membrane here still. Okay, we'll have our endothelial cells still lining the blood vessel here. Okay, our smooth muscle cell layer is still going to be intact. Okay, out here, so this is still going to be the layer of smooth muscle cells here, but now we've got an additional layer in between the basement membrane of the endothelial cell layer and the smooth muscle cell layer out here. So these cells here, which I'm colouring in red, these are our smooth muscle cells. Okay, so this new layer that's formed here, this is going to be the layer that's referred to as hyaline. Okay, now it's a connective tissue layer. Okay, so you form a whole new layer of connective tissue here, which I'm colouring in magenta, okay, which I'll explain in a moment. Okay, right, so you get this whole new layer of thick connective tissue in between the basement membrane and the smooth muscle cell layer, and this causes the narrowing of the lumen of the blood vessel. Okay, so you get this narrowing of the arteriole, and this also causes the arteriole to become much harder, okay, because you've now got that really thick, solid layer of connective tissue. So that's why this is known as arteriolosclerosis, because you're going to harden the arteriole. Okay, right. So why have I coloured it in this vivid magenta colour here? Well, basically, when you stain arterioles which have undergone this hyaline arteriolosclerosis with a stain known as periodic acid Schiff, okay, which is a common stain used in histology, okay, periodic acid Schiff, which is often abbreviated down to P for periodic, A for acid, and then S for Schiff. Okay, when you stain these arterioles which have undergone hyaline arteriolosclerosis with periodic acid Schiff, you find that it appears this vivid purple colour, basically, or magenta as it's often described, which is this sort of colour here. Okay, in addition, it takes on a very sort of glassy appearance. Okay, so it looks very sort of perfect when you see it in histological slides stained with periodic acid Schiff, and therefore it's called hyaline arteriolosclerosis because hyaline means a glassy texture. Okay, right, so what's the problem with this, basically? Well, the problem with this is that it cuts down the blood flow to the kidney, basically, because if we go back to this picture, this is going to be happening in both the afferent arteriole and the efferent arteriole of the glomeruli all over the kidney. Okay, that's going to be reducing the blood flow through the glomerulus. It's also going to be reducing the blood flow on, and remember, this blood supply here, not only does it reabsorb all the nutrients from the fluid in the tube, okay, via the cells that line the duct, okay, but it also supplies blood to all the cells of the ducts, basically. So all the cells that line the lumen of these ducts here, they're going to be getting blood from these blood vessels, basically. So if you are reducing the blood flow through the afferent arteriole and the efferent arteriole, it means that all of these cells are going to have their blood flow compromised, okay, and that can cause the nephrons to die, okay, and that's why this is so dangerous. So the nephrons can die because of this. Okay, so what can then result because of the nephrons dying? Well, then what can eventually happen is you can get renal failure, okay, because if you lose your nephrons, then the function of the kidney is going to be compromised. Okay, you're not going to be able to remove waste products from the blood as effectively. Okay, so hyaline arteriolosclerosis of the afferent arterioles and the efferent arterioles can lead to, firstly, the nephrons dying, okay, and what that can then lead to is renal failure. Okay, and what renal failure means is the kidney is now failing to remove adequate waste products from the blood, and it's doing it so badly that it is now going to be life-threatening. Okay, so it's going to fail the rest of the body effectively, because now the whole body is at risk of dying because the kidney isn't doing its job properly, which is to remove waste products from the blood. Okay, renal failure is also called end-stage renal disease. Okay, you might hear it referred to as that as well. Okay, so let me just explain then why renal failure actually kills you. Okay, so the job of the kidney is to remove waste products from the blood. Okay, if the kidney is not working properly, then waste products are going to remain within the blood. Okay, and that's called uremia. Okay, so uremia refers to waste products that are usually removed in the urine being in the blood in a high concentration. So what examples can I come up with of waste products that should be removed by the kidney but which are now going to be present within the blood? Well, the obvious example after which the entire thing is named is urea. Okay, so urea is a very simple molecule. Okay, it's got a ketone group like so, with two amino groups on either side, one here and one here. Okay, and it results as a waste product from a huge number of different metabolic pathways. Okay, so urea is one of the waste products that's going to build up within the blood if the nephrons are not doing their job properly. Another waste product that's going to build up in the blood is creatinine. Okay, another important thing that needs to be excreted by the kidneys. Okay, right, so these are two examples of waste products that are going to build up. Now, why is this so dangerous? Why does these waste products building up in the blood cause problems for the body? Well, basically they cause problems to the heart, okay, and also to the brain. Okay, so the two essential tissues, we come always back to them. Okay, so firstly, the waste products can lead to dysrhythmias of the heart, okay, which means that the electrical activity in the heart is going to be disturbed. So remember, in order for the heart to contract in the exact way that it needs to contract, i.e. the atria contracting first and then the ventricles contracting after that, you require an incredibly orchestrated sequence of electrical activity within the heart. Okay, if that sequence of electrical activity gets disturbed, that's what's known as a dysrhythmia, and it's going to cause problems with the beating of the heart and the delivery of blood around the body. Okay, so what can happen is if these waste products build up in the blood, it can cause problems on the heart with the heart cells, and dysrhythmias can ensue, and what this can result in is cardiac arrest. Okay, so the heart stopping beating basically, okay, because of a dysrhythmia. Okay, so that's one of the incredibly serious consequences of these waste products building up within the blood, and that obviously will be fatal very quickly if it's not dealt with immediately. Okay, and the other thing that these waste products can cause on the level of the brain, they can put you into a coma. Okay, so again, we've seen loads of examples of things that can put you into a coma in this video. If waste products build up in your blood, again, it can cause this extended period of lost consciousness because of damage to the function of the brain. Okay, which is called a coma. Right, so that's one of the forms of pathology on the level of the kidneys that is caused by diabetes. You get this hyaline arteriolosclerosis in the afferent arterioles and the efferent arterioles of glomeruli in the kidneys. This compromises the blood flow to the cells of the ducts of the nephron, okay, and when they don't get blood, they're obviously going to die, so you get nephrons dying in the kidneys. Eventually this will lead to renal failure if you lose enough nephrons, okay, which is where the kidney is no longer capable of removing adequate waste products from the blood for it to be sustainable and suitable for life. Waste products build up in the blood, such as urea and creatinine. That's known as uremia, and uremia can result in dysrhythmias on the level of the heart, which can cause cardiac arrest and coma on the level of the brain. Okay, right, and that's how renal failure generally kills people. The other problem that chronic diabetes causes to the kidneys is that it increases your risk of getting urinary tract infections. Okay, so let me talk a little bit about urinary tract infections. Okay, so the urinary tract usually ends up getting infected with bacteria from the gastrointestinal tract. Okay, and before we go any further, let me just say that I'm going to, from now on, abbreviate urinary tract infections down to UTIs. U for urinary, T for tract, and I for infection. Okay, right. So, basically, there are two bacteria species that inhabit the gut, okay, and that's perfectly fine, but because of the proximity of the exit of the gastrointestinal tract to the exit from the urinary tract, what can happen is these bacteria can end up transferring from the gastrointestinal tract to the urinary tract. Okay, now usually the immune system is good enough to deal with this, okay, and it doesn't generally take hold in most people. However, in diabetes, something causes you to be at increased risk of these bacteria successfully colonizing the urinary tract. Okay, now that might be because of the high amount of glucose in your urine. If you've got a lot of glucose in your urine, maybe the bacteria can use the glucose in your urine, and that's why the urinary tract becomes a nice place for them to live. Alternatively, it could be because diabetes causes slight immunosuppression, and therefore your immune system is less good at getting rid of these bacteria from the urinary tract when they go into the urinary tract. Okay, so what are the general bacteria then that transfer from the gastrointestinal tract, the GIT, to the urinary tract, the UT? Okay, well, the two key examples are firstly Escherichia coli, E. coli, and also Enterococcus faecalis. Okay, now, these are two very different bacteria. Okay, what they have in common is that they both colonize the gastrointestinal tract, faecalis. Okay, so E. coli is a gram-negative rod-shaped bacterium. Okay, so if you gram stain it, it therefore appears red. Okay, gram-negative bacterium appear red when you gram stain them. Okay, and it's in a rod shape like so. Okay. Enterococcus faecalis, meanwhile, is firstly a coccus, which means that it's a round bacterium, okay, and in addition, it's gram-positive rather than gram-negative, which means that when you stain it, it appears blue. Okay, right. However, both of these bacterial species can move from the gastrointestinal tract and successfully colonize the urinary tract. Okay, so let me just explain how this usually occurs. So, what happens is they begin by colonizing the urethra, generally. Okay, so they transfer from the gastrointestinal tract into the entrance of the urethra. Okay, they begin by colonizing the urethra, okay, and then they go into the bladder. Okay, so here is the bladder here. And when they colonize the bladder, when you get an infection of the bladder, that's called cystitis. Okay, specifically, itis really refers to inflammation that results because of the bacterial infection. So cystitis means inflammation of the bladder because of the bacterial infection. Okay, but it's kind of used to imply a bacterial infection of the bladder rather than the strict meaning, which is the inflammation due to a bacterial infection of the bladder. Okay, right. Then coming off the bladder, you'll have the two ureters here. Okay, like so, which will then join onto the two kidneys. Okay, so I'll put the left kidney here, and then we'll have the right kidney here. Okay, right, so the bacteria then colonize the bladder here, that's called cystitis, and then they move up the ureters, and then the first bit they get into is the renal pelvis. So remember, the place where all the urine collects before it then goes into the ureter and down into the bladder. Okay, so the first thing that you get is bacterial colonization of the pelvis and the consequent inflammation of the renal pelvis. Okay, now there's a special name for inflammation of the renal pelvis because of bacterial infection, and that's known as pyelitis. Okay, so you get renal pyelitis, basically. Okay, then what will happen is the bacterial infection will spread into the nephrons, and you'll then get inflammation of the nephrons. Finally, when you have got inflammation of the nephrons as well as inflammation of the renal pelvis, that condition is then known as pyelonephritis. Okay, pyelo referring to the renal pelvis, nephritis then referring to the nephrons. Okay, so this is the thing then that people say that you are at risk of if you have poorly controlled diabetes. Pyelonephritis. Chronically elevated blood glucose puts you at increased risk of these urinary tract infections, which the most serious consequence is that they can result in pyelonephritis, infection of the nephrons basically and the renal pelvis. Okay, now the infection, along with the consequent inflammation that it's going to drive, is going to cause mass destruction of nephrons. So this can also race you on towards renal failure, or end-stage renal disease as it's also called. Okay, so this is another problem that people with diabetes mellitus face in their kidneys. Okay, they're at increased risk of getting these urinary tract infections, which can cause huge destruction to the renal structures. Okay, right. So that's enough of the kidney then. We're now going to turn our attention to another thing that results from microvascular disease. This increased risk of urinary tract infections, I should say, this isn't part of the microvascular disease. This is grouped as part of nephropathy, but this obviously isn't because of problems with tiny blood vessels, okay? The previous bit that I looked at was the consequence of problems with the tiny blood vessels which supply the nephrons. Okay, now we're going to continue on with our microvascular disease. We're going to look at diabetic retinopathy, which results because of problems with very small blood vessels that supply the cells of the retina with blood. Okay, so let me get another piece of paper then. Right, okay, so this one is going to result because of problems with capillaries. Okay, so diabetic retinopathy then is the next topic. Okay, so firstly let me tell you about the normal structure of a capillary, okay, so that we can look at what changes occurs in diabetes mellitus because of the chronically elevated blood glucose levels, and then we'll look at the consequences that this is going to have for the retina. Okay, right, so firstly let me draw a capillary then. Okay, so let's say this is the basement membrane then of the capillary, and I'll colour it in a moment. Capillaries only consist of a single layer really, which is the endothelial cells. Okay, so they are very, very simple, very, very tiny blood vessels. Okay, they have a basement membrane like so, and then the endothelial cells, this will be an endothelial cell like so. Okay, and then maybe there'll be another endothelial cell here. These are tiny, tiny blood vessels is the point that I'm trying to get across. Okay, this is a single cell that pretty much gets its entire way around the edge of the capillary basically. So the lumen of a capillary is only just big enough for a single red blood cell to move through. So they are tiny, tiny little blood vessels consisting of this basement membrane here with the endothelial cell here, which I'll abbreviate down to EC for endothelial cell. Okay, right. Now, there is a few cells lining the outside of the basement membrane. They're sort of scattered around, so you don't always have one. It's not a confluent layer of cells. They're just sort of dotted around. So if I draw a picture from the side of a capillary here, let's say this is a tiny little capillary, sort of dotted around the place, you'll have these cells on the side of the capillaries, okay, but it's not a confluent there. There will be certain portions where there is no cell around the edge of the basement membrane. Now, what are these cells called? These cells are referred to as pericytes, okay, so peri means around the edge of, site means cell, so this is a cell that's around the edge of the capillaries. Okay, and the pericytes have slight contractile properties, so they can sort of control the size of the lumen of a capillary. Okay, they also have roles in deciding what comes across the capillaries, okay, and the permeability of the capillaries. Now, in diabetes mellitus then, the poorly controlled blood glucose levels, okay, so chronic high fasting blood glucose level and also too large postprandial glucose spikes causes firstly the pericytes to die, okay, so you lose pericytes. In addition, it causes a huge expansion of the basement membrane. Okay, so the basement membrane of these capillaries becomes much thicker basically, and this is quite similar to what happened in hyaline arteriolosclerosis, where you've got a thickening of the connective tissue underneath the basement membrane. Okay, again we're getting this thickening of connective tissue. Okay, right, so what does this result in then? Okay, well, it results in, unfortunately, in the capillaries being far more leaky. Okay, even though the basement membrane is now thicker, the loss of the pericytes and also the damage to the endothelial cells, that's an important part of this. The endothelial cells do not like being in a too high glucose concentration, okay, and too high glucose concentration for a very long time damages them. Okay, so their function will be reduced as well. Okay, so what ends up happening is these capillaries become incredibly leaky and they start letting out far too much fluid into the interstitial fluid. Okay, right, so this is going to cause problems in the retina where you have capillaries. Okay, so let me just give you a reminder of the structure of the retina then. Okay, so I'm going to draw a picture which is what you see if you look into someone's left-hand eye. Okay, so I'm going to draw a picture of the back of the retina. Okay, so on top of all of the cells of the retina, you're going to have the blood vessels moving, so they face into the middle of the eye where the vitreous humor is. Okay, so they're on top of all the cells. So let me draw different portions of the retina. So firstly, there is a very important portion over here, which is known as the optic disc. Okay, and this is where the optic nerve joins the back of the retina here. Okay, I should call it optic disc, not optic nerve. Okay, so that bit generally appears lighter than the other portions, so I'll colour that in yellow. Okay, then there's a portion in the middle here, okay, which is known as the macula, because it appears darker than the rest of the portions of the retina, and macula means dark. Okay, so this portion I'll colour in red here. Okay, now the macula contains a very special region known as the fovea. Okay, in its centre. So this is the fovea at the centre of the macula, and the fovea is the area where you have the greatest visual acuity. Okay, because the cells, the photoreceptors in the portion of the fovea, each have a single neuron innervating them, whereas in other portions of the retina, a single neuron will innervate loads of photoreceptors. Okay, the consequence of that is that you can't tell when a neuron's activated which specific photoreceptor it was that was activated. Okay, so it means that your resolution is reduced, whereas here you have incredible resolution, incredible ability to see detail. Okay, so the fovea is the portion that you are focusing on a certain area when you want to look at something in detail. So, you know, if you're seeing something out of the corner of your eyes, you're not seeing it in that much detail. If you want to look at something in detail, you make sure that your fovea is centered on that area, okay, so that you can see it in highest visual acuity. Okay, so that's that area there. Okay, and then the rest of the retina appears a colour in between the optic disc and the macula. So I'll colour the rest of the retina in orange here. Okay, right. Now, over the top then of all the cells of the retina, you then have the blood vessels that are going to supply the retina. Okay, now we don't usually see these. Our brain has learned to remove them from the picture. Okay, but they are there. Okay, so you have loads of blood vessels that are spreading out from the optic disc, okay, because the blood vessels that are going to supply the retina, they arrive with the optic nerve, so they spread out from the optic disc. Okay, now, the capillaries of this blood vessel system that supplies the retina, they are going to become leaky just like the capillaries everywhere else in diabetes mellitus, and this causes particular problems in the retina. Okay, it firstly causes fluid accumulation in the retina, particularly in the macula. Okay, so you get what is known as macular edema. Okay, edema means fluid accumulation. Okay, so macular edema refers to fluid accumulation within the macula of the retina. Okay, and it's resulting because of these leaky capillaries that have resulted because of the poorly controlled diabetes mellitus. Okay, now, what then does macular edema cause? Well, it's going to cause blurring of vision. You can imagine that if you put loads of fluid in front of these cells, that's going to cause problems with your vision. Okay, and what it actually does is it reduces your visual acuity, so it causes blurring of vision. Okay, now that's the first stage of diabetic retinopathy, the macular edema. Unfortunately, it gets worse, okay, because what seems to happen is, for reasons that aren't fully understood yet, you seem to get angiogenesis being initiated in the retina as well. Okay, so angiogenesis in the later stages of diabetic retinopathy, what happens is you start angiogenesis. Okay, now that means that you start making new capillaries. Okay, your blood vessels start expanding. You make loads of new blood vessels in the retina, okay, over the retina. Now, the problem is these blood vessels don't seem to have been very well built, okay, and they tend to leak even worse than the original blood vessels that you had that have been affected by the diabetes mellitus, okay, and they tend to end up actually bleeding, okay, so worse than these blood vessels. These were just leaking fluid. These new blood vessels that you're making are actually going to be leaking blood cells, okay, so you end up bleeding onto your retina. Okay, and obviously if you end up with loads of red blood cells all over your the front of your retina, that's going to completely block your vision. Okay, so what you get is complete clouding of vision. Okay, clouds of vision, and this unfortunately can result in blindness. Okay, so that's diabetic retinopathy. The too high blood glucose in the blood seems to firstly drive these changes in the capillaries that were originally in the retina, which leads to them leaking fluid into the retina, particularly the macula, which causes blurring of vision. Okay, and then somehow it causes blood vessels to be built, new blood vessels to be built in the retina, and these are not particularly well constructed, and they end up bleeding, leaking blood into the retina, so you end up with a layer of blood in front of all of your cells of your retina, and that causes clouding of vision and then blindness. Okay, so diabetic retinopathy is one of the leading causes of blindness in the world. Okay, right. Finally then, we'll move on to the final chronic complication of diabetes mellitus that I want to talk about, which is diabetic neuropathy. Okay, so again, this is going to result from this thickening of the basement membrane of the capillaries that supply nerves this time, okay, and also the increased leakiness. Okay, so firstly let me tell you about how nerves get a blood supply. So if we draw a nerve here, now remember a nerve is a collection of loads and loads of axons running together. Okay, so when you learn about nerves in anatomy, what those are an incredibly large number of axons of neurons running together. Okay, so absolutely loads of axons running together. Okay, now these do require a blood supply. Okay, and they do have a blood supply. Now this blood supply that they have is known as vasa nervorum. Okay, vasa refers to blood vessels. Okay, nervorum refers to the fact that it's supplying nerves. Okay, so I'll draw one of these blood vessels close by to the nerve here. Okay, right. Now, basically, if the capillaries of this blood vessel system, of this vasa nervorum system, become leaky, then what happens is that all the fluid ends up leaking out before any blood ever gets to certain areas. Okay, so basically because of the leakiness of the blood vessels, the capillaries leak out the fluid to earlier portions of the nerve, and then later portions of the nerve don't get any blood at all because it's all leaking out in earlier portions of the nerve. Okay, so that causes the nerves to start dying. Okay, so you get neurodegeneration, basically, neuron death. Okay, now this is particularly generally bad to the lower limb. Okay, the lower limb is particularly affected by this reduction in blood supply to nerves, and you particularly get nerves dying that are supplying the limb. Okay, now what does this cause? Well, this causes loss of sensation to the lower limb generally. Okay, so what we'll have here is a lower limb, like so. And if you lose sensation to the lower limb, the particular problem area is that you lose sensation to the foot. Okay, and when you lose particularly pain to the foot, that causes a problem, because usually you end up standing on all sorts in life. Okay, now if you stand on a splinter, usually it causes a huge pain, and that tells your brain to get off that splinter. Okay, if someone with diabetic neuropathy that has destroyed the neurons that supply pain sensation from the foot to the central nervous system stands on a splinter, they are not going to feel anything, okay, and they will just continue standing on that splinter. In addition, things like wearing shoes that are too tight for you, usually that will cause the rubbing of your feet, okay, it would start to cause a blister, okay, and it will cause a lot of pain for you, so you'd stop wearing those shoes. Okay, if someone with diabetic neuropathy that has affected the feet in this way wears shoes that are too tight, they're not going to feel anything. Okay, so generally what happens is they now treat their feet really badly, okay, and it results in ulcers of the feet. Okay, now what's an ulcer? An ulcer just refers to a break in an epithelium of some sort. So when you have a stomach ulcer, you have a break in the epithelium that lines the stomach. A skin ulcer is basically a hole in the skin. Okay, so you lose the epidermis and the dermis. So if I show you the skin here, okay, this is the normal structure of the skin. You've got the epidermis here, okay, and the dermis below that. And then, of course, as we saw earlier, the subcutaneous fat is then below the dermis. If you suddenly have a break in this, if you just remove all of this structure from here, okay, and you just have a hole there, that's what's known as an ulcer. Okay, so because of these traumas that you now get to your feet without getting any pain, they result eventually in ulcers forming. Okay, now there's a problem with having an ulcer, which is that the skin is one of your barriers to bacterial infections, okay? It's a huge part of the innate immune system. It's a way that you protect yourself from pathogens, okay? If you've got a break in it, now what can happen is you can get infections in there, okay? And these infections, again, will not cause that much pain because you've lost sensation to your foot, okay? And then they can spread throughout the foot, and it results in a medical emergency that requires amputation generally, okay, to prevent septicemia. Okay, so diabetic neuropathy, which leads to problems with the foot, is one of the leading causes of non-traumatic amputation. Okay, now this is known as diabetic foot, this syndrome of damaging your feet in this way. Okay, right, and it causes the need for amputation. Okay, right, so that now finishes our discussion of the chronic complications of diabetes mellitus. What I want to move on to in the next video is discussing the anti-diabetic drugs. Okay, now, the anti-diabetic drugs that we are going to discuss are used to treat type 2 diabetes mellitus majorly. Okay, type 1 diabetes mellitus we've discussed is treated with insulin replacement. Type 2 diabetes mellitus can be treated with insulin replacement, but it's kind of the last option basically. Okay, it's the thing that you go to if the drugs aren't working. So we're now going to talk about drugs that can help to tame diabetes mellitus type 2 without using insulin.